testes of the brain, since they look like a set of testicles with two lobes, the anterior and posterior pituitary. And very similarly, they too release hormones that helps the body do many functions. So starting with the anterior pituitary, this is the largest part of the pituitary gland and is responsible for synthesis and release of most pituitary hormones. So let's look at the hormone list here. Starting with ACTH, the adrenocorticotropic hormone. The effect on target is that it stimulates the adrenal cortex to release aldosterone and cortisol. And the stimulus for release is stress. The next one is FSH, the follicle stimulating hormone. In men, sperm production is the effect on the target, and for women, ovarian follicles for the release of eggs. And the stimulus for release is the GnRH, the gonadotropic releasing hormone. Next is LH, the luteinizing hormone. For men, its function is in testicular, and for women, this is the most important part. It plays a key role in ovulation, the release of the egg. And the stimulus is GnRH once again. Next is GH, growth hormone. This increases during anabolic metabolism, as well as cartilage growth and catabolism of fat, as well as blood glucose and insulin effects. And its stimulus is normal growth and development. Next is PRL, the prolactin. It stimulates the production of milk in the breast, and the stimulus for release is estrogen, pregnancy, and nursing. Next is TSH, the thyroid stimulating hormone. It stimulates thyroids to release T3 and T4 for thyroid needs. Okay, now moving on to posterior pituitary. The posterior pituitary does not necessarily produce hormones directly, but rather stores and secrete hormones produced by the hypothalamus, which is what it's connected to. Now for the hormones, ADH, the antidiuretic hormone. So for the memory trick, we use ADH, adds the H2O, because the effect on the target is it adds water back into the body by telling the kidneys to reabsorb water. And its stimulus for release is for decreasing blood pressure, pain, and even high osmolality inside the blood. Basically really thick blood. So we need to add more water back to the body to dilute that thick blood. Now lastly, we have oxytocin. The effect on the target is maternity. It stimulates uterine contractions and lactation of breast milk. And its stimulus for release is labor and delivery of a newborn or infant that is breastfeeding. Okay, now switching gears to the thyroid. The main ones to know is that T4 converts into T3, the active thyroid hormone, with the help of TSH, the thyroid stimulating hormone. So let's play the segment now from the MedSurg course. So as you know, just like all endocrine hormones, it's a big game of telephone, or dominoes if you will. So the hypothalamus releases TRH, which then tells the anterior pituitary to release TSH, the thyroid stimulating hormone. And can you guess what the thyroid stimulating hormone does? Well, yes, guys, it stimulates the thyroid. Oh, how stimulating. So once stimulated, the thyroid pops out three most important key players, guys. Our T3 and T4, which are basically our active thyroid hormones. And also calcitonin, which basically puts a ton of calcium into the bone. So our memory trick is it tones down the calcium in the blood by putting a ton of calcium into the bone. So calcitonin, a ton in the bone. Now our thyroid hormones T3 and T4 are the main focus for our thyroid conditions. Hypo, we have low T3 and T4, and hyper, we have high T3 and T4. And to make this, your body needs dietary iodine found in salt. So iodine deficiency is a major cause of that hypo-low thyroidism in developing countries. So what causes our high T3 and T4 in hyperthyroidism? Guys, the number one cause is our autoimmune disease we talked about, Graves' disease. We think Gaines' disease in high thyroid. But also too much iodine means too much thyroid hormone. And even treating hypothyroid conditions, guys, if we give those patients too much thyroid meds, like levothyroxine, which leaves too much thyroid hormones in the body, we can eventually cause a hyper condition. So guys, balancing these two conditions is kind of like a teeter-totter, or basically like a seesaw. Hyper will be the exact opposite than hypo. So low T3 and T4 in our hypo comes from that autoimmune disease, guys, called Hashimoto's, that low and slow thyroid. Now, other causes are low iodine in the diet. And a big one, guys, big test tip here, pituitary tumor. And even anti-thyroid treatments like a thyroidectomy, where we take out that thyroid gland and now the body can't produce any thyroid hormones at all. Now, as far as diagnostic tests, guys, don't let the NCLEX trick you here. So here's a tip. Always focus on T3 and T4 first. Guys, don't even look at TSH initially. If T3 and T4 are high, then it's hyperthy. And guys, if it's low, then it's hypo. Now, you don't have to memorize any of the values. The NCLEX will give you the ranges. Okay, now after seeing T3 and T4, then we look at TSH. So TSH will always be the opposite of T3 and T4 here. Guys, TSH is just trying to slow the hyper and amp up the hypo. So guys, as far as signs and symptoms, it's super simple. Everything in hyper will be high and hot, and everything in hypo is going to be the exact opposite, guys, low and slow. Okay, now for the parathyroid glands. The big one to know is PTH, the parathyroid hormone. So use the memory trick PTH, puts the calcium high inside the blood. So let's play that segment now.
The parathyroid glands are almost exclusively responsible for the regulation of blood calcium. So think PC, like a computer. P is for parathyroid, and C is for calcium. And the levels are typically 9.0 to 10.5. However, some books will say 8.5 to 10.0. So be sure to know what your textbook says. The main point is the calcium, guys. If the parathyroid hormone is high, that means calcium is high. And when the parathyroid is low, what is the calcium? Yes, low. So hyperparathyroid means hypercalcemia, and hypoparathyroid means hypocalcemia. That's why I remember PTH, the parathyroid hormone. As an acronym, PTH puts the calcium high. Think of a thermostat or a light switch. This is called our negative feedback loop. When calcium's high, PTH shuts off. And then when calcium's low, PTH turns on. But remember, PTH puts the calcium high in the blood. Now, how does it do this? Calcium is increased in the blood by 3 ways. So remember the acronym RIB, R-I-B. R is for renals, which reabsorbs calcium, so it's not lost in the body. I is for intestines. They help to increase blood calcium by absorbing it from food, and the help of vitamin D activation. This is a big tip right here, guys, so please write this down. Both calcium and magnesium love vitamin D, and they all work together. So you'll often see calcium, magnesium, and vitamin D all in the same multivitamin. And B is for bone, since our hard bones are made up mostly of calcium. And when your body needs more calcium, it usually drains the bones to get it. So with too much PTH and hyperparathyroidism, there is too much calcium in the blood. It's like every organ is being squeezed for their calcium. Like PTH is the bully, taking all their lunch money. Remember, PTH puts the calcium high, so blood calcium goes up, right? So we have stones, moans, and groans. Stones in the kidneys, moans from broken bones, and groans from rock-hard bowels. So PTH makes bones weak by taking calcium from their storages. This makes them brittle, meaning big risk for fractures. Okay, so the kidneys, the washer machines of the blood, have to filter out all that excess calcium from the body and into the potty. But they get overloaded, and we get kidney stones, aka renal calculi, from all that overload of calcium. And lastly, our GI, Mr. G.I. Joe. Our intestinal tract gets overloaded with calcium, causing rock-hard bowels, a common sign and symptom of hypercalcemia, too much calcium. Okay, so remember, the top 3 signs of hypercalcemia are usually stones for kidney stones, moans for fractured bones, and groans for constipation. So guys, again, for hyperparathyroid, remember hypercalcemia. Everything is swollen and slow. with high calcium. And for hypoparathyroid, that means hypocalcemia. Remember Baja California from low calcium. And as you can see, we used our electrolyte emoji, Mr. Cocky Calcium, from our electrolyte course.
Okay, hopefully you liked that segment from Nurse Blake. Now moving on to the adrenal cortex. This is the outer region of the adrenal gland, and it's divided into 3 separate zones. So the 3 parts include the zona glomerulosa, the zona fasciculata, and the zona reticularis. And the adrenal medulla is the inner part, or the middle, of the adrenal gland. And this makes the fight and flight catecholamines, which is a huge test tip. So please be sure to write this down. Epinephrine, called adrenaline, and norepinephrine, called noradrenaline. So let's play the key points for all the adrenals in this next segment.
As you know, the adrenals sit on top of the kidneys and help the body adapt to stress by using MAC hormones. Just like Mac computers, the adrenals look like the Apple logo. So remember the acronym MAC. M stands for mineral corticoids, like aldosterone, aka aldosterone, our steroid hormone, security guard bouncer to the kidneys, in the renin-angiotensin-aldosterone system. Again, remember Al. He adds sodium in water in to balance blood pressure, and L lets potassium out of the body and into the potty. Next is A, for androgen steroids to help with hair and sex. And our first C is for cortisol steroid, our very famous stress hormone. Lastly, C is for catecholamines, epi and norepi, also called adrenaline, are fight and flight hormones, which increase heart rate and blood pressure. Okay, so now that we reviewed the basics of normal physiology, what's going on in hyper-Al? Well, we have high aldosterone, right? So the ability to add sodium and water into the body is super high, which leads to hypernatremia and hypertension. And the loss of potassium is greater, so hypokalemia sets in, and we get a higher pH level as the body loses more hydrogen ions in the urine. This is called metabolic alkalosis.
All right, that wraps it up. Thank you so much for watching. Don't forget to
Now, Addison and Cushing is all about the steroids. Typically, when we think of someone on steroids, you think of some big, hairy weightlifter, right? So in the same way, in Addison's, think we have an absence of steroids. We have too little. We need to add some in Addison's. So clients typically present small and skinny and very frail and weak, with a very odd tan. And with Cushing, it's the exact opposite. Big, round, and hairy. So think a big cushion of steroids with Cushing's. Basically, too much cortisol. We can call him Cushy Carl. Kind of like a big, round, hairy airbag. So think Cushing as more cushion for the pushin'. Now pump those NCLEX brakes. Guys, the majority of the NCLEX questions come from this section. So we took over 10,000 questions while creating the script. And I can almost guarantee you, this part will be on your exam in the form of a SATA question. So again, Addison's, we have an absence of steroids. We need to add some steroids, guys, so everything will be low. We'll have low blood pressure, which is the most critical. We'll have low weight from that water loss. Key words here, very skinny and very weak. We'll have low temperature from that cold intolerance. Low hair, known as hair loss or alopecia. Low mood or depression or irritable. Low energy, low sodium, guys, big one here. Hyponatremia, 135 or less. And this comes with a big salt craving. Also slow or irregular periods or menstrual cycles. Now big ones here, 2 highs, the 2 double P's here, pigmentation and potassium. So remember, double P's for the double D's in Addison's. So guys, write this part down. The NCLEX loves this, big keywords. High pigmentation or hyperpigmentation, also called bronze pigmentation. And high potassium over 5.0, aka hyperkalemia. And since potassium pumps those muscles, we get muscle spasms and EKG changes. So high potassium is high heart pumps with peak T waves and ST elevations. And for Cushing's, it's the exact opposite. So just think big, huge cushion of steroids, big, round, and hairy. We get big blood pressure with big sugars and big sodium. Big NCLEX tip right there. and a big round hairy body with big weight or weight gain from that water gain. And this leads to our NCLEX favorites, guys. Big belly or truncal obesity. Big keyword right there. Now, 3 more big words for the NCLEX here. Big face called a moon face, a big buffalo hump called a fat pad, or big hair called hirsutism, which I call a hairy suitism. And also big stretch marks known as purple striae on the face and abdomen, and big red face or rosy cheeks. And lastly, big infections or slow wound healing, and a big risk for fractures from brittle bones or osteoporosis. Now, I know what you're going to be thinking, guys. You're going to be thinking, oh my gosh, that is a lot to remember, right? But guys, it's very simple. Just think big and just think low. So to help you remember the biggest test topics for the NCLEX, just use your memory tricks, add and cush. So adds for Addison, A for added tan and added potassium. Again, think the double P's here. Pigmentation and potassium over 5.0. D is for decreased weight. Water loss usually means weight loss. So we'll get skinny patients and not truncal obesity. And not the moon face or buffalo hump. Guys, that's Cushing's. Also D for decreased blood pressure, which again is the most critical. Guys, that low blood pressure can kill the patient in Addisonian crisis, which we'll be covering very soon. But also decreased hair, sugar, and energy. Keywords here are fatigue, alopecia, and hypoglycemia. Lastly, S for sodium loss or below 135, and S for salt craving. Again, not hairy body or thin skin. Guys, that's Cushing's. And for Cushing, simply remember Cush. C for cushion of fat. So truncal obesity, and 2 more keywords here, write these down. Moon face and buffalo hump. U for unusual hair growth, also called hirsutism. Remember that hairy suit. And S for skin that has stretch marks, called purple striae. And lastly, H is for high sugar, high BP, and even high weight. Again, guys, the NCLEX will try and trick you. It's weight gain, not weight loss. So just think big, round, and hairy. Now let's break down that pathophysiology for those nursing exams. And a little side note here, guys. The majority of the NCLEX questions come from priority signs and symptoms and the treatments, not specifically from this patho section, FYI. So as you know, the hypothalamus in the base of the brain starts the steroid domino chain. Man, that should be a rap song, huh? Secreting CRH, which tells the pituitary to squeeze out ACTH, which eventually stimulates the adrenal cortex to produce steroids, which controls the 3 S's: sugar, salt, and sex. So cortisol, our stress hormone, increases the sugar during times of stress. Aldosterone adds the salt and water to the body and lets go of potassium. And androgens control hair and sex. But our main key player here is cortisol, the stress hormone, the synthetic version ending in zone like prednisone or hydrocortisone. Guys, normally these steroids shield and protect us from stressful situations. So remember the 4 S's. Surgery, which is a really big one on tests, but also stress from work and school, like during finals week, we produce more cortisol. Or even emotional stress from like a bad breakup or even some baby mama drama. And lastly, guys, keywords here: sepsis or sickness, or aka infection, and even strenuous activity can increase this cortisol. So steroids help to suppress the inflammation and swelling caused by those stressors, pretty much protecting us from the harshness of reality. Sort of like a big fat airbag, it deploys during times of trauma. So it's a little easier to understand the signs and symptoms, right? So in Cushing's, we have too much steroids, guys. We end up looking like a big fat cushion, right? Big sugars and slower immune response with slower wound healing. Big salt means big swelling, leading to a big round body with big blood pressure and big sodium or hypernatremia. And big sex and hair, leading to a big hairy body called hirsutism, aka that hairy suit. And Addison's, we have the exact opposite, guys, absence of steroids, which again, any added stress can kill our patient, called our Addisonian crisis, which we'll cover pretty soon. Now, typically, absence of sugar will have hypoglycemia. Absence of salt means absence of swelling, low BP, and very skinny, with salt cravings and low sodium, below 135. And absence of sex and hair, basically we see it as alopecia. Now, normally the body turns these hormones on and off like a light switch, called our negative feedback loop. Too much, the body turns it off, and too little, like during times of stress, the body turns it on. But you guys already know the problem here. Cushing is stuck on high, and Addison is stuck on dry, with absent hormone, so production is off. Okay, so what's causing our adrenals to mess up? Yeah, why though? Now, Addison is usually caused by our memory trick ADD. So A for autoimmune disease, where the body basically kills the adrenals or pituitary. This is called a primary cause. Or secondary causes from D and D, like diseases like cancer or infection like TB, and even just trauma to the adrenals, like from a car accident or falling off a roof. Now, on the other side, Cushing is either caused by drugs from outside the body, called an exogenous cause, usually coming from high steroid medication, ending in zone, like prednisone. Often we see this when giving high doses over time with inflammatory conditions, like asthma, COPD, and even rheumatoid arthritis patients. This makes the adrenals think they can stop producing steroids. They sort of close up shop and go on vacation. But high cortisol can also come from inside the body, called an endogenous cause, like tumors on the adrenal or pituitary, and even small cell lung cancer. Guys, big NCLEX tip right there. Write that one down. Small cell lung cancer. Now, the treatments are pretty simple. For Addison's, we just add some steroids, ending in zone like prednisone and hydrocortisone. Now, we can also add IV maintenance fluid to bring that blood pressure up. And in Cushing's, we control the causes by cutting out the tumor or slowly decreasing those steroids causing the problem. Now, we always slowly decrease those steroids to prevent that low blood pressure crisis. So for Addison, we use the acronym ADDI, like Addison's disease. We add SON, guys, those steroids during times of stress to avoid that Addisonian crisis. So big test tip right here, guys, write this down. Teach patients to tell their doctor about increased stress from work, school, or emotions. We have to increase their steroid doses, guys. Always stressful times, we increase the steroids. Huge NCLEX favorite. Now, D is for a diet high in protein, carbs, and sodium. Cortisol helps convert proteins, carbs, and fat to energy, so keep these high in the diet. Also, don't stop taking steroids abruptly. Guys, we never abruptly stop hormones. In this case, it leads to Addisonian crisis. BP so low it will cause death, aka shock. And D, don't believe this medication will cure you, guys. It will not cure you. Always more education is needed for any patients thinking hormones will cure them. And I, indefinitely on this medication. This is a lifelong hormone replacement therapy, guys. No cure. You're always on hormones, what's known as a forever drug. And lastly, we can always wear a medical alert bracelet. Now, lifelong or long-term steroids come with a few precautions. So here are the top 7 most tested steroid side effects and nursing considerations. Now, I can guarantee you at least 3 or 4 will be on your exam. So remember the 7 S's of steroids ending in zone, like prednisone. S for swollen. Steroids swell the body, so weight gain means water gain. We see a big moon face with big blood pressure. Big keywords here: sudden, excessive, or rapid weight gain. Teach patients to report 1 pound in 1 day, or even 2 to 3 pounds in a few days. S for sepsis or infection from low WBCs. Guys, this leads to slow wound healing, which is a huge risk for a fever and infection. Always priority on the NCLEX. Any low-grade fever, even 100 or 37.8 degrees Celsius, can be very serious. Now, sugar will be increased. Hyperglycemia over 115. So guys, for diabetics on steroids, steroids increase the sugar. So we increase the insulin. Write that one down. Big key word for the NCLEX. Now, skinny muscles and bones or osteoporosis, big risk for fractures. And sight, specifically risk for cataracts. So we're referring these patients to optometrists. Another NCLEX tip, guys. Everyone always misses that one on SATIC questions. And lastly, to prevent Addisonian crisis, we always teach patients to slowly taper off. never an abrupt stop. And again, for stress and surgery, we always increase the dose with increased stress. Write that one down. I saw that one like 3 times on the NCLEX review. Okay, now how do you treat Cushing? Well, we simply cut it out, right? The tumors or the steroids causing the problem. Pretty simple, right? Wrong! Guys, cutting off an adrenal or pituitary, or even suddenly stopping steroids can lead to an Addisonian crisis. We're talking blood pressure so low it can kill the patient. Now this is called shock. So remember, we always slowly decrease or taper off steroids ending in zone, and if we cut off tumors. So remember, if we remove any endocrine gland, we have to replace these hormones. And a key word here, lifelong hormone replacement therapy with no cure. We're just managing it with meds. So when a question comes up along the NCLEX or even your exam stating what statement made by the patient requires additional teaching after that adrenalectomy? Guys, key word here, lifelong hormone replacement therapy, and never stop those hormones. It will lead to Addisonian adrenal crisis. So think ADD for Addisonian or adrenal crisis. A for added stress like a broken leg or car accident. Or if Addison disease patients go into surgery and don't increase their dose. Guys, they're like a ticking time bomb. Stress will kill. The second A is for abrupt stop. Patients forget to take their prednisone steroids, or they go on vacation and don't refill their prescription, and boom, Addisonian crisis. Now this leads to our low blood pressure, which is shock, and then death. So what's your first priority action as the nurse? Well guys, what do you do in low blood pressure? No, you don't go clock out or cry to your mommy. Guys, our first priority is to get that blood pressure up. So our very first nursing action is to add zone steroids, IV push. Write this down, guys. Again, hydrocortisone or prednisone IV push. That's the NCLEX #1 for Addisonian adrenal crisis. And after, we can always treat the low fluids and low sugar with either IV normal saline and even dextrose IV solution.
All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also,
wrapping up type 1 versus type 2 diabetes, which I call diabetes. Since this blood is turned to mud from that thick sugar, and over time this high sugar destroys the vital organs and blood vessels, leading to kidney failure, nerve damage, blindness, and even high blood pressure. Now to clarify, DM is for diabetes mellitus, not for direct message. So guys, it doesn't go down in the DM. And it's not the same as diabetes insipidus. Guys, DI is a diuresing peeing problem, not a sugar problem. Now for pathobasics. As you know, blood sugar naturally increases when we eat. The pancreas releases insulin from the beta cells and also enzymes to help break down food for fuel. So remember, insulin puts sugar and potassium into the cell, making our hungry cells really happy. Now, when we give insulin, both sugar and potassium decrease in the blood since it's going into the cell. Now, if we don't have food, then the pancreas has a backup plan. It releases glucagon hormone to break down stored glucose, aka glycogen, in the liver, which increases sugar in the blood. Glycogen is kind of like a glucose brick wall. So remember, glucagon means glucose gone out of the liver into the bloodstream, which increases blood sugar. So again, when blood sugar is high, like after you eat, insulin is released. And when blood sugar is low, like when you exercise or forget to eat, glucagon is released. So in diabetes, insulin is the problem here, guys. Type 1, we have none. Since the body has killed its own pancreas, it produces no insulin. And people are born with it. It's an autoimmune disease. So type 1 you can pass on to your son, since it's genetical. And these patients are insulin dependent for life. Big key word. Now in type 2, remember, few insulin receptors work, since the problem is you, your diet and lifestyle. The high in sugars and sitting sedentary lifestyle. We're talking junk food like sodas, white breads, and sweets, which eventually leads to obesity. And our cells now are lazy and overused. The insulin receptor sites are like an overused keyhole. They've basically been worn out, and now just ignore the insulin. This is called insulin resistance. So just think, in type 2, the cells are through. They quit responding. Now, the risk factors for developing diabetes. Guys, in type 1, there are none since it's mostly genetical. You can pass it on to your son. And in type 2, the problem is you, your diet, and a little bit of genetics. So we screen for metabolic syndrome, which increases the risk of not only diabetes, but also heart disease and stroke. Now, this is big on exams in the NCLEX. So we use the acronym BOL for metabolic syndrome. So guys, 3 or more criteria means we have metabolic syndrome. So B for blood pressure meds and high BP, over 130 systolic. Our next B is for blood sugar medications or high blood sugar over, key word here guys, write this down, 100 fasting, over 100 fasting. O is for obesity, big keywords here guys, waist size over 35 for females and over 45 for males. And lastly, L is for lipids that are high. This is not good. We're talking high cholesterol panel. Write these numbers down, 200, 150, and 100. All should be low except the HDLs, our happy lipids. That one should be over 40. Now guys, if these numbers are off, it could mean metabolic syndrome. And this contributes to insulin resistance in type 2 where the cells are through, again like an overused lock. The cells stop responding from the overuse of insulin. Now I can already see questions coming up on your exam and NCLEX, so I recommend writing this BOL memory trick out at least 15 times the week of your exam. Now to help you, here's a common practice question. Which clients are most at risk for developing metabolic syndrome? A 35-year-old male with triglycerides of 140. Nope, guys, the triglycerides are under 150, so that's okay. How about option number 2? 48-year-old female with a fasting blood glucose of 105. Guys, yes, fasting sugars over 100, metabolic syndrome. Option 3, 55-year-old female with a waist size of 40 inches. Oh yes, over 35 waist. And a 28-year-old male with a blood pressure of 135 over 85. Guys, yes, the systolic pressure is over 30. Lastly, a 42-year-old female with high HDLs of 55. Guys, no, those are the only lipids that should be high, over 140. Just think the high lipids for HDL. Now, speaking of type 2, technically not a cause, but a very particular sign of insulin resistance. Keyword, write this down, brownish or dark thickening on the neck and armpits, or even hyperpigmentation and skin tags. This is what's called acanthosis nigricans. Now, as far as diagnosing diabetes, the top 3 must-know labs for the NCLEX that you will get tested on, guys. Write these down. Number 1, normal glucose must be 70 to 115. Number 2, fasting glucose less than 100. And third, hemoglobin A1C must be less than 6.5. Those are big NCLEX key numbers there. Write those down. Now, as you know, the A1C test is our long 2 to 3 month sugar audit, and is best used to see if patients are being compliant with controlling their blood sugars the long term. So remember, below 6 is controlled and fixed, and over 6.5, we gotta revise. So review diet and exercise compliance for our type 2 problem, basically the U problem. And with type 1, insulin compliance, always on the NCLEX. Now, the most deadly is low sugar, under 70, called hypoglycemia, since it causes brain death. So we say hypogly, the brain will die. Now, all the other numbers on this chart just help diagnose the severity of diabetes, but are not highly tested on the NCLEX. And speaking of something that's not highly tested, a little side note here. The GTT, or glucose tolerance test, is when we give an 8-ounce drink of syrupy glucose to see if insulin is doing its job by putting the sugar into the cell. If it's not, then the sugar will go high. But guys, that's not usually tested on the NCLEX directly. Now, signs and symptoms and causes of high sugar or hyperglycemia. Just think, the blood is turned to mud. So the body tries to get rid of all this thick syrup with the 3 Ps. First P for polyuria, a lot of urine. Basically, the body tries to urinate it out. Now, polydipsia is a lot of drinking fluid. The body tries to dilute all that sugar. Now, third is polyphagia, which is excess hunger as cells starve, since insulin's not doing its job to get sugar inside the cells. Now, a little side note, this is not polyphasia, which is a psych disorder. Now, the causes of acute high sugar can be caused from the 4 S's. The number one key term on the NCLEX is sepsis or infection, guys. That's a number one cause. But also stress from surgery or hospital stay, and even skipping insulin doses. And a big one here is steroids, those zone-ending drugs like prednisone. That is a big cause. But high sugar can also be caused from hormone therapy like estrogen. Now, we treat that high sugar with insulin to put that sugar into the cells. So for your test, I know this is going to come up. Yes, we increase the insulin during stress like sepsis, surgery, and especially with steroids. And guys, no, the patient's not on insulin forever. Once the S's stop, then the insulin stops. And guys, big key word here, if the sugar is still high after the insulin, that's a critical situation. Always call the doctor or HCP. Now on the other side, for hypoglycemia, that low sugar below 70, guys, just think low brain function, which leads to rapid brain death. So remember, hypogly, the brain will die. We're going to be watching for critical signs, the cool, pale, sweaty, or clammy. We need to give that patient some sugary candy. Now, typical NCLEX keywords include high wash. So headache, irritability, weakness or anxiety, and even shakiness and hunger. It's kind of like a Snickers commercial. You're just not you when you're hungry. Now, since hypo is so deadly that hypogly, the brain will die, our very first treatment is giving sugar. So on the NCLEX, if the patient is awake, then we ask them to eat. Specifically juice, soda, crackers, and low-fat milk. Not high milk or peanut butter. Big key word right there. The fat actually slows down the sugar absorption. And if they're asleep, big key word here is not alert or unarousable or only arousable to painful stimuli. Then we stab them with dextrose IV. And always reassess sugars every 15 minutes after giving insulin. Now, causes of hypoglycemia. They usually come from exercise, alcohol, and even insulin peak times. Big NCLEX tip right there. So watch out for diabetic athletes who exercise. If your patients exercise, then give extra glucose. Keywords, bicyclists, swimmers, and even runners. Now, alcohol is also a big no-no, technically with any disease, but it actually lowers sugar, doesn't increase it. And insulin peak times is when patients are most at risk for that low sugar. So remember, if there's a peak time, then we give a plate of food. Since hypogly, the brain will die. Now, 3 common test questions for that low or high sugar. Here we go. Test question number 1. A client with type 1 diabetes is only responsive to painful stimuli. With a blood sugar of 42, what's the first action taken by the nurse? Guys, this is the worst case scenario here. Anything less than 70 is bad. So hypogly, the brain will die. Now, patient is not alert, only responsive to painful stimuli. So if they're not awake, we can't ask them to eat. Technically, the patient's asleep, so we stab them with dextrose IV, and then we reassess blood sugar in 15 minutes. Oh, and if you chose option 4, I'm shaking my head at you. Question number 2, which medication could cause hyperglycemia? Now guys, before you even look at the options, you should already be saying steroids increase the sugar ending in zone like prednisone. So guys, zone ending steroids. Steroids increase the sugar. Now the tricky question number 3. The non-diabetic client is admitted for a kidney infection that has now turned septic. The blood sugars have increased from 150 to 225. What is the best answer to give a family member who's asking why insulin is used? So option number 1, the client now has type 2 diabetes. No, that's a wrong answer. Option 2, insulin is given to control hypoglycemia. Totally wrong. It's for hyperglycemia. Option 3, high sugar is common during infection and stress to the body. And insulin will help lower the sugar until the infection resolves. Guys, yes, option 3 is the best option. Super high sugars, we want to land like a plane, slow and steady. We don't want to crash into that hypoglycemia, that low sugar with low brain function. Now, if you chose option number 4, you nasty. Now, we get many complications from this long-term high sugar, where the blood is turned to mud. It's like dumping thick syrup into your blood vessels. And guys, imagine years and years of this. This destroys and scars the blood vessels called atherosclerosis, or atherosclerosis, and leads to more infections since bacteria love sugar. Ultimately, it destroys all the organs. So the kidneys are washing machines that wash the blood. Guys, these guys die, which is called nephropathy or renal failure, indicated by creatinine over 1.3. So remember, NCLEX keyword, creatinine over 1.3 means injured kidney, and also means no more PP. So patients either get a transplant or go on dialysis to wash the blood. And nerves die, called neuropathy, so patients get loss of sensation. And they don't even realize when they get small cuts and injuries on their hands and feet. Not to mention the sugary blood. So we call diabetic feet delicious treats for bacteria. This leads to infections and slow wound healing, and then to amputation and cutting off of those dead feet from all the infections. Now in the eyes, the small blood vessels break, called retinopathy, which leads to blindness. So NCLEX key term here, guys, frequent eye exams are recommended. And in the heart, we get hypertension from all that high tension on the heart, eventually leading to heart disease and then ultimately heart attacks. Lastly, in the brain, we can have CVAs or strokes from all those narrow blood vessels that either burst from aneurysms or get clots. Now, as far as diabetic treatments, guys, we're going to cover all the diabetic pharmacology, including the 7 rules of insulin. So write these down. These are the most tested. So remember, type 1, we have none or no insulin. The body destroyed the pancreas, so they are insulin dependent for life. And type 2, the problem is your diet, and a little bit of genetics. So remember, type 2, we have few insulin receptors working. So the first treatment is to fix your habits. So we focus on diet and exercise to help repair those broken receptors, aka increase insulin sensitivity. Then we give drugs like oral meds and insulin, but only if diet and exercise don't manage it alone. So for our 7 insulin rules, peaks equals plates, guys. Typically we give food during a peak, since the greatest risk for low sugar is during those insulin peaks. Guys, the #1 way to kill your patient is not giving food during the peaks. So know your peak times. During peaks, we monitor for that low sugar below 70. Now, #2, if you get low sugar below 70, or if your patient looks shaky or trembly, the classic signs, pale, cool, sweaty, or even clammy, give that patient some sugary candy. The priority key terms again are the A's and the S's. If your patient is awake, ask them to eat. Always sugary food here, guys. So soda, juices, crackers, and low-fat milk. Not high-fat milk or peanut butter. Guys, fat will slow the sugar absorption here. And if they're sleeping, then we stab them with IVD-50. Sleeping means unresponsive or unarousable. Responsive only to painful stimuli. So don't just go stabbing sleeping diabetics here, guys. Always assess the sugar and symptoms first. And after you give sugar, always reassess 15 minutes later. We always follow up after any intervention, always checking the sugar and the symptoms. Now the 3rd rule, insulin with no peaks and no mixes. It's our long-acting dudes. Guys, the memory trick is the old dudes, like grumpy old men who have been here for a long time. They're past their peak and they never mix well with others. They're basically antisocial. So the keywords, draw up in 2 separate syringes. So remember, Detromir lasts all year, and Glargine is large lasting. And Lantus is like a lantern. It burns all night. Now #4 here, guys, a big NCLEX favorite. They're gonna try and trick you. So the IV only insulin is regular insulin. So remember our memory trick here. Regular insulin is ready to go IV, or regular is right in the vein. Not NPH, not Lispro, not Lantus. Guys, no one except regular. He's the VIP for the IV. Now, #5, we draw up insulin. Always clear to cloudy. Guys, just think you want clear days before you want cloudy ones. So draw up regular insulin first, the clear, and then NPH, the cloudy second. 6, we rotate locations every 2 or 3 weeks. And the best location is always on the abdomen. Keywords here, near the umbilicus, navel, or belly button. And guys, we never aspirate, basically never draw back on that plunger. It'll cause scar tissue and swelling. And also, we never massage or add heat after sub-Q injections. Now lastly, #7, DKA, the extreme high sugar condition in type 1 diabetes, guys. We have a separate video for that, but here's the big NCLEX question here. Do we give insulin on sick days? What if the patient's not eating or basically too nauseous to eat? Well, yes, we give insulin without food. We just monitor that glucose closely. So remember, we always increase the insulin during the S's, like stress, like surgery, sepsis or infection, and even sickness and steroids. Now, as far as insulin types, who put sugar and potassium into the cells. Now, these are must-knows for the NCLEX, specifically the peak times, coming up 60% of the time in all endocrine questions. And a little FYI for the NCLEX. Guys, we're not using brand names anymore, only generic. So no more Novolog or Novolin. If your school is still using this, then they're behind on the times. So again, for reinforcement, our first group is the long-acting guys. Our antisocial old dudes. Guys, they have no peak and never mix with others. Big NCLEX keyword again. Draw up in separate syringes, never mix. These guys have no peaks, so they require no plates. Or basically, they're not food dependent. And hence, they have a minimal risk for that hypo low sugar. So the brain is pretty safe here. Again, our memory trick here is Detromere lasts all year. It's long lasting. And Glargine is large lasting. Now NPH are cloudy, dude, always being mixed. So remember the N's. Intermediate insulin, and we never give it IV drip or bag. Guys, never put anything cloudy in an IV bag. Now, when we do mix it, always mix clear to cloudy. Clear days before cloudy. So we usually give NPH 2 times per day, not 4 times a day. So don't let the NCLEX trick you. Now, the peak time is between 4 and 12 hours, but most dangerous in the middle, around 5 to 6 hours. So make sure you have a plate of food with that peak. Next is regular insulin that's ready to go IV. Guys, again, he's the only dude allowed IV push or IV bag. If you haven't wrote that down, please write it down. His peak is between 2 and 4 hours, so monitor closely for signs of low sugar. That shaky, pale, cool, and clammy, we need to give some sugary candy. Now finally, our most deadly insulins. They're the #1 priority since they have the #1 fastest peak and onset. 15-minute onset, guys, with a 30 to 90-minute peak. So rapid acting insulin, remember, Lispro, Aspart, and Glulisine. So our memory tricks here. For Aspart, you gotta remember to move your Asparts, guys. It's really fast. And Lispro, just think Lespro. Less time for the onset. It's 15 minutes. And Glulisine, it goes fast like a limousine. It's super fast. So we give these during meals. Keyword here, patient is eating or there's food at the bedside. Again, guys, patient must be eating in 10 to 15 minutes, not before the food's delivered. Usually an NCLEX question. Those peak times are the must-knows for the NCLEX. So I'd recommend printing this study guide out and reviewing it every day the week of your exam. Now, a little insulin quiz. We're covering the top 3 most tested NCLEX questions on peak times. Here we go. Again, peaks are priorities. The fastest way to kill your patient is not giving a plate of food with the peaks. So remember, peaks require plates. So we drew a little plate on the flag showing the peak time. Now, our red rapid guides are the most deadly. Always monitor for hypoglycemia, that low sugar below 70. You're gonna see shaky, sweaty, pale, and clammy, so we give that patient some sweet juice, soda, or candy. Okay, question number 1. The nurse gives regular insulin at 12 p.m. for lunch, but the patient doesn't finish their food. So when's the greatest risk for that hypoglycemia? Guys, the risk for regular, look at the peaks right here, 2 to 4 hours. So if given at 12, the answer is between 2 p.m. and 4 p.m. Never before and not after. So guys, memorize these peak times. Now question number 2. A client is on Aspart insulin. When should the nurse advise him to eat? Again, guys, this is an onset of 15 minutes with a peak time between 30 to 90 minutes. So Aspart, get your Asparts moving. The best answer is the soonest, so eating within 10 or 15 minutes. Now question number 3, the client on Glargine is asking the nurse when is the best time to eat during this insulin? Well, guys, Glargine is large lasting, long acting, no peaks. So no peaks require no plates. Pretty tricky one there. Now for a little bonus question. We saw this a few times in our NCLEX review. So the client taking insulin NPH with dinner at 7 p.m. What time is the client most at risk for that hypo low sugar? So NPH has a 4 to 12 hour peak. The most at risk, guys, we're looking at the green peak here. 5.5 to 6 hours has the most peak. So the best answer here is midnight or shortly after. Now, before we move on to the insulin infusion pump, guys, the best way to memorize these insulin peak times is to print off the study guide or cheat sheet we provide, and guys, write this out at least 7 to 15 times the week of your exam. Now for insulin pumps, or CSII, the continuous subcutaneous insulin infusion. Guys, the number one benefit is the steady dose of insulin for our type 1 kids who forget to take their insulin and are basically non-compliant. The biggest benefit and the coolest part here is we have fewer swings in blood sugar level. So not high and not low anymore, guys. It's a nice even basal rate. That's a big key word, even basal rate. Now, how do you manage it? Well, we usually check the blood sugar 4 times per day, and you push, keyword there, push an insulin bolus button at meal times to get that sugar into the cell. Now, what if you get an NCLEX question about a machine malfunctioning, guys? What do you do? Do you assess the patient or do you assess the machine first? Well, we always assess the patient first and then machine second. Now, that's really big on the NCLEX. Now, for oral agents, these are only for type 2 since the body responds to few insulin. Guys, the pancreas isn't dead here. It's just overworked. So oral agents help to decrease blood glucose and make the body more sensitive to insulin, kind of like repairing a broken lock. So we only use these after exercise and diet fail to manage type 2 diabetes. Big keywords there, after diet and exercise have failed. Now, in general, we never take oral meds with iron, calcium, and even antacids that contain calcium. These guys block absorption in the stomach. So guys, be careful. They're always in over-the-counter pills and medications.
All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate, and even your instructor. See you guys in the next videos.